Hello and welcome to another Piper Pod. Today we're going to continue along with pharmacology, and this time we're going to look at anticoagulant agents. Now, anticoagulant agents are things that are used in the emergency setting, so we'll have them in the case of PEs and DVT treatment, but they're also used prophylactically as well. So they are definitely going to be something that you work with in the future in nursing or dealing with patients in the military that are on oral anticoagulants. So I think it's a good idea to go over them, get a good outline of how to use them, what the different types of anticoagulants are out there and how they work, and then look at considerations that need to be put into place when using them on patients, both in the acute setting and then also in the long term. So to start off, we'll just have a quick look at the clotting cascade. Now, the reason we need to look at the clotting cascade is obviously every anticoagulant drug that we'll talk about is going to have some effect somewhere within the clotting cascade. Now, the cascade itself is made up of 13 different factors. Now, the problem is everyone always says 13 factors, and 13 factors are numbered, so you'll see the Roman numerals from 1 through to 13, but in reality there are actually only 12 factors, because factor 6 that was assigned to a particular factor has been noted in recent times to be just another factor that's already been part, so it's already been labelled. So if you're sitting a test you say 13, but in reality it's only 12, just as a bit of a side note. So a lot of the factors in there are just written as factors 1 through to 13 for ease of understanding. Because obviously if we had the big words, it'll get confusing. But a lot of the factors, or all the factors, apart from factor 6, have a known factor associated with them, whether it's fibrogen, prothrombin, tissue thromboblastin, even ionized calcium has a particular name. There's certain factors like factor 10, 9 and 12 that have been given names associated with who found them, like factor 9 being the Christmas factor, 10 is the Sturt-Prower factor, and factor 12 is the Hangman factor, just for curiosity base. The way the clotting cascade works, finally getting to the point, is you have two distinct different pathways. You have an intrinsic pathway and an extrinsic pathway. The extrinsic pathway is associated with being cut. So cut associated with cutting external tissue as well as endothelial tissue at the same time. So obviously you're going to have external hemorrhage. That is a large factor and needs to have clotting activated quite quickly. So the extrinsic factor is small. It contains factor 3, which is the tissue thromboblastin, and then heavily involved with factor 7, the stable factor or proconvertin, and then that's it. Okay, taps into factor 9, and then we move on to factor 10, which is the same as both of them. Okay, so that's for your extrinsic side of the house. The intrinsic side of the house happens internally, so it's either as a result of the Valcal's triad, which we'll speak about later, or mostly associated with endothelial damage. There's more steps associated with it, and it actually uses thrombin in order to finally get its last activating factor of factor 8 before it can tap into factor 10. What is common in both of the pathways, regardless of which one you actually take, is once you get to factor 10 and in the presence of calcium and vitamin K, the same pathway continues. Okay, and we have activations of different factors all the way down using thrombin, and therefore en masse turning prothrombin into thrombin, and then using thrombin in order to convert fibrogen into fibrin. Now, fibrin is the final factor that is needed, and it is assisted by factor 13, which is your fibrin stabilizing factor. Now, once all these are done, we end up with a cross-link fibrin net. Okay, you may have seen in the picture, and that collects red blood cells, it collects the platelets, collects all the leukocytes, and it builds a net over the actual area in order for healing to be repaired. Okay, that's normally what happens. All the factors are required in the combat of hemorrhage and the ability to clot. Calcium is essential, as too is vitamin K. So that is the clotting cascade in a nutshell, and we'll move on to the bad types of clotting. Okay, why do we need antithrombolytics, and anticoagulant agents when blood clotting is obviously such a life-saving factor that our body does? Okay, and the big reason is we need to go back to the Valkow's triad. Now what that is it's a 3 individual elements, if you will, or factors that encourage thrombosis to occur. Okay, so that's what it is. So the Valkow's triad is mixed up with endothelial damage, that's the main one, so damage to the inside of the vessels. There's also a change in the flow of blood, mostly associated with stagnant living. And there's also an environment that encourages coagulopathy. Okay, so an environment that encourages coagulopathy. So if we look at the known risk factors on the screen here, where we have flying, surgery, heart problems, pregnancy, hormone therapies, smoking, so on, each one of these is contributed to one of the Valkow's triad. Okay, so the coagulopathy side of the house is associated with your family history, your hormone therapy, your surgery, and in some cases, your cancer. When we start looking at a change in blood flow, we move into your flying, heart problems, pregnancy, lack of exercise, and cancer as well. Okay, we can also mix in a little bit of dehydration. When you're looking at endothelial damage, then we're looking at the big ones associated with your smoking, your bad diet, your heart problems, and once again, your cancers. Okay, so each one of these is associated with tapping into a bit of that Valkow triads, and the end result is going to be that a thrombus on the side of the actual vessel is going to form. Okay, this is compounded by high cholesterol, having a huge amount of low density or very low density lipoproteins floating around the body, which is going to create a thrombus, and then you're going to end up encouraging clotting to form on the end of the actual plaque buildups, and that thrombus has a risk of breaking off and becoming an emboli, and that's when it becomes most dangerous, because you'll have a stroke, or you'll have a PE, or you'll get stuck in a particular part of the limb and you'll end up with gangrene, and a whole bunch of other problems can be associated with an emboli. And it all starts from internally a clot forming and then breaking off. So that's why we need antithrombolytic agents. Before we kick into the actual medication, we'll just have a look at a few blood tests that we do in order to test whether or not the agents that we're using are working or not. So we looked at the clotting cascade. Now there's 2 main tests that are associated with the clotting pathway. Now obviously there's a hell of a lot more. Okay, you can actually look at your platelets number, you can look at your thrombin time, but these 2 are the main ones. So PT is mostly associated with the extrinsic pathway, and it stands for prothrombin time. So the amount of time it takes for prothrombin to be formed. And that is it. Now the way it is measured, the most common way, is using your INR level. Okay, INR level is your international normalized ratio. And now this is a very common test associated when people are on warfarin. So PT is used all the time to monitor warfarin anticoagulation therapy. Now as you can see on the picture in front of you, when we look at the normal PT time, it's about 12 seconds to clot. So if you and I were to take this test, it should be 12 seconds, and that would be represented as an INR of around 1. Okay, even up to 1.2 is considered normal. Now the way you get the INR score is you divide the time of coagulation for the patient's blood by that of a known standard. Okay, so 12 seconds, that's the known standard, and you divide that. And when you're usually looking at warfarin control, okay, when you're looking at an INR range for someone who's on warfarin, it should be between 2 and 3. Now the other common blood test is used when someone's on heparin. Now there's two different types of blood tests within the same one. So the partial thromboplastin time and the activated thromboplastin time. Now what this one does is it can be used bedside, and it's a really short test to monitor whether or not heparin's working. Okay, and a lot of the times the APPT test will be used in order to ascertain whether or not you need to give more heparin or less heparin. So a lot of the times it will be, especially if you're giving it as an infusion or any metered dose IV, they have a bedside testing that will use the APPT in order to test the results and then adjust the heparin dose as needed. So the normal time should be 25 to 39. You can even say 30 to 40 seconds for the activated PPT. Okay, the non-activated or normal PPT can take around 60 to 70 seconds before the clot will actually form. Therefore, it takes a little bit longer, which is why they have an activated one. So when we look at the difference between activated and non-activated, simply mean if you look at each one of those factors, each one of the factors needs to be activated before it can move on to the next step. By utilizing an activated PPT, it just adds the activated compound to the mix itself. So it bypasses the step to activate, and therefore it's done a lot quicker. Okay, and this test here mostly looks at the intrinsic pathway. Okay, but technically just the normal PTT test does incorporate the extrinsic pathway as well. Okay, the bottom line is if you have anyone on anticoagulation therapy, there may be a need for continuous testing. So in the acute setting, when you're getting your serum levels monitored, you can do these tests every 4 hours for people who are on heparin, or even bedside in an emergency sense. And even people that are on oral anticoagulations, they will have a requirement to continually test their bloods in order to ascertain the effectiveness and whether or not they're within the therapeutic range itself. Okay, moving on to the actual drugs, we'll look at the two classes of drugs that are most commonly used. So we have heparin, and then we have low molecular weight heparin. Okay, now that's also been known as unfractionated and fractionated heparin. Okay, so firstly looking at heparin itself, the way that it works is you need to understand that there's certain factors in the body that are associated with breaking down clots or stopping the formation of clots. Now there's four main factors that take care of that, but the main one is the antithrombin 3 factor itself. Okay, and heparin acts on working with that particular one. So it binds directly to AT3 and it enhances its ability to inactivate the clotting factors of factor 10A, okay, so the activated factor 10, and also thrombin itself. Okay, so heparin works on factor 10 and thrombin itself, which is factor 2. Now this obviously will prevent the formation of fibrogen and then fibrin as well, so it will stop the actual formation of a clot. Now looking at the medication itself, it's measured in units. Okay, so this one is very particular. It often comes in 1,000 units per mil concentration, so you need to be absolutely precise. Now the general rule of thumb when giving it, obviously there's a bunch of doses out there, but the reason it's measured in units is basically it means that 1 unit is the amount of heparin needed to prevent 1 mil of blood from clotting for 1 hour. So that's generally how many units you will need to give. Okay, now the effects of heparin are very, very quickly. So that's why we use it in the emergency stents. When we have a positive Doppler for DVT or we have signs of PE, we use heparin. Okay, so it's very useful for transplant, heart and lung machines, things like that. It's often covered with heparin itself. It's used in dialysis machines because it is so fast acting. The big thing about heparin is there's two ways in which you can administer heparin. You can either go deep subcut, and that takes about 60 to 90 minutes to kick in, and it lasts for about 8 to 12 hours. Or in the emergency sense, it's given IV. Okay, so it's the only drug that we can actually give IV, and that's given through an infusion or an injection itself. And that has immediate effects and a half-life of around, well, less than 2 hours realistically. Now it can't be given oral at all, okay, because it basically will just be deactivated by the stomach acids. Okay, so it's a fat-soluble protein, so it will just be destroyed by the stomach. It's also not advised, not impossible, but not advised to give it IM because of the risk of hematomas. Okay, so obviously it has a very local effect as well, so you'll have a risk of causing hematoma in the very vascular spaces. You need to monitor the APTT, obviously, especially if giving it IV. Now, heparin's often used first until an oral anticoagulant can kick in. So you'll often get a couple of doses of heparin for starters to get your levels up, and then you'll move on to oral, because that can take around 48 hours for oral to be fully effective. Now, heparin, one of the rare ones, because it's so large, it's such a large molecule, it doesn't actually cross the placenta, so it is safe for pregnancy. Now, the side effects, as you could imagine, is bleeding, okay, hemorrhaging, over anticoagulation, if you will, and you can also get heparin-induced thrombocytopenia. So that's a overall reduction in platelet counts as well. So definitely something to look out for. Now, if you're giving it in an infusion sense in an area, make sure you have the antidote available. So the antidote is protamine sulfate. So protamine sulfate should be on standby, especially if you're ever giving a heparin infusion. Alright, looking at the other, we have our low molecular weight heparin. Okay, so this is just like heparin, but smaller. That's why it's often called a fractionated heparin. Now these are classically your enoxaparin, so your clexane, you'll definitely know that one, and your delteparin, okay, or fragment itself. So these ones here, because they're smaller, okay, they still bind to the antithrombin 3 or the AT3 factor, but they're only large enough to actually stop factor 10A. Okay, that's it. So they're not large enough to actually work with the thrombin side of the house. Okay, it needs to be at least 18 units to do that. So it only works on your 10A. Okay, so whilst it's very similar, it still will end up stopping the formation of fibrogen, okay, because obviously 10A needs to be present to turn prothrombin into thrombin to move on from there. So it stops that. It stops the formation of thrombin and therefore stops the formation of fibrogen as well. Now this one here is different in concentration, so the big thing we need to know is its measurement is in milligrams, not in units like heparin. Okay, so massive difference. Clinically, there's not a lot of difference associated with it, but it often has a longer half-life, so you'll give it 12-hourly because it has a lasting effect for about 24 hours. Its subcut absorption is better. It has a 90% bioavailability. There's not as much monitoring required when using low metabolic weight heparin or fractionated heparin. In high doses, just to let you know, I forgot to mention with heparin, high doses of heparin can actually turn off all clotting factors. Okay, so making clotting pretty much impossible. So it has a huge risk associated with it. So sometimes using these ones, when it's not a massively acute setting, is a safer way to go. Okay, so it's less likely to develop bleeding and thrombocytopenia. Bruising at the sites of the subcut injections is pretty common, so you just need to be aware of that. As I mentioned, these ones are only delivered subcut, and they're often given in the treatment for DVTs and PEs, obviously not in the acute setting, but mostly prophylactically before surgery or after surgery, myocardial infarcts, things like that. Now, the difference is there's no actual direct antidote for fractionated heparin, okay, apart from time, and you can also give whole blood as well to increase the number of actual clotting factors within it. Okay, so you can give fresh frozen plasma will help, as well as platelets itself, and that's generally the antidote if you're given too much fractionated heparin itself. Okay, moving on, we'll move on to a very common one, and that is warfarin. Now, warfarin, for something completely different, actually works on vitamin K. Okay, so vitamin K is needed in order for factor 2, the thrombin, 7, 9 and 10 to be activated. So in the absence of vitamin K working, then you're not going to get the clotting side of the house. And the cool thing about warfarin is it only turns it off for clotting. So you can still use it in calcium reabsorption and general metabolism, but it cannot be used in formations of clots. Okay, so that's very, very useful in a sense. Now, obviously, it can be quite dangerous, okay, because you are giving an element that destroys the synthesis clotting factors of vitamin K, which means that it has the inability to bind. So without the vitamin K, you cannot have the factors in order to form the clot, in order to finally get to fibrogen to stop the bleeding. So monitoring is 100% required in this particular case because it has a huge chance of increasing bleeding. So this is where we use our INR. Now, it also needs to be mentioned when people are on warfarin, because it's usually a long-term thing, is they need to be careful with their diet. So if they have a diet that is high in vitamin K, so a chamomile, garlic, cabbage, then it's going to have a lesser effect associated with it. It also reacts a lot with other drugs that we'll talk about in a bit. But the other thing to remember is Australia has 2 types of warfarin available. Okay, so there's your Coumadin and your Maravan. Now these 2 ones are not bioequivalent. Okay, so just to mess with the patients that are on warfarin just a little bit more, okay, they are not bioequivalent, which means that if you get started on Maravan, patients need to know that they cannot change to Coumadin. Okay, it can't happen. So will not have the same effects, and you're more likely to have adverse effects associated with it. Now, as far as drug interaction, it's very susceptible to over-the-counter medication and certain antibiotics. Okay, so your NSAIDs, your sacchalates like aspirin and ibuprofen, okay, your simvastatins, and antibiotics, penicillins and ceftriaxone are ones to watch out for. Now, the reason that it has such a high affinity is either it affects the INR or you have huge association with competitive protein binding. So warfarin is highly protein bound. Okay, that's why it has such an effective half-life. So if someone was on aspirin, it is also a protein bound molecule, then what happens is warfarin gets kicked off. So if warfarin gets kicked off, then you have more activated warfarin in the system at one time. Okay, so when warfarin is bound to the protein, it's like a slow release. When the warfarin wears off and gets metabolized, the next one gets released, and that sort of thing. If a whole bunch of them gets kicked off by a competitive drug, then you'll have large amounts of warfarin floating around the system, which obviously can be very dangerous. Okay, so warfarin was, for a long time, the only oral anticoagulant agent. Okay, but recently there's been a few more that have come onto the market. And a few more, I mean there's a lot more. So these particular ones, so direct oral anticoagulations, they all work by inhibiting the formation of fibrogen. Okay, that's the end goal, obviously. That's what all anticoagulants do. Okay, now there's two different types, okay, slightly different ways. So you've got your dabigatran, which is involved in thrombin inhibitory. Okay, so it binds directly to thrombin and prevents it converting fibrogen into fibrin. That's what it does. Okay, your rivaroxaban and your enoxaban, they factor 8 inhibitors. So they directly link factor 10 and prevents the formation of prothrombin and therefore fibrogen eventually. So these are used a lot prophylactically. Okay, so they're used in patients who are having surgery, hip surgery, joint surgery, things like that. It's used as prevention for people that have high risk of hyperlipidemia, huge cardiovascular risk, so for stroke and emboli, people who have long-term unstable AF. Most of them are excreted renally. They have a half-life of around 12 to 14 hours. Now, this is generally longer in the elderly because of impaired renal impairment. Obviously, from the age of 40, you have a 1% reduction in creatine clearance factors. So, therefore, you'll have to be wary of that if using it in elderly. Now, the side effects is if the dabigatran is given to someone with renal impairment, then you must have a lower dose. Okay, absolutely must have. And that's same true using with any of the anticoagulants that affect factor 8 as well. If you have renal or hepatic impairment, you need to be careful with the doses. Side effects are similar to heparin. Okay, so you have your bleeding and your thrombocytopenia. These have come into play mostly for an alternative to warfarin. Okay, so they're mostly used as an alternative to warfarin. There's no need to have routine monitoring with these particular ones. And the biggest problem is because they're so new, we don't actually have any long-term safety data to say, yep, use them long-term, it's safe. Okay, so the jury's still out on that one. Okay, now the good thing is there's not a lot of significant drug interaction or food interaction with these ones as well. So there's no diet control, less risk of mistakes than warfarin. So overall, it's a easier drug for patients to take. Now, obviously, if you have drugs that are associated with increasing contaminants, like your aspirin, clopidogrel, or NSAIDs, then you just need to be careful as well. So whilst it's not a massive interaction, there is still interactions associated with them. Okay, let's move on to the patient. So our clinical decision making, things that we need to think about before, or how to educate our patients and before we administer anticoagulants on order. So the big thing is we have to realise that anticoagulants are part of the high-risk medications. Okay, so the A-pinch medications that we mentioned right at the start, they're the H side of the house. Okay, so heparin and other anticoagulants are definitely on the list. Okay, so they have a huge risk of complications, especially if you're dealing with heparin, because units are difficult to work with if you haven't done it before. Okay, so when we're assessing the patient, we need to look at them, the appropriateness of that patient getting anticoagulants. So if the patient is on other medications that interact, or if they're a huge fall risk, then that has to be noted. We need to look for the obvious contraindications. Ulcerative colitis, inflammatory disorders is a big one, especially of the GIT, has a huge risk of causing bleeds, even small bleeds, and obviously anyone who's suffering from haemophilia. We need to look at their history of clots, clotting ability, bruising, liver, renal disease, things like that. We have to get a baseline set of OBS. Okay, hypertension is a huge risk factor associated with formation of clots, so it needs to be taken into account. And we need to have a clotting profile, which means PT and INR as well. If we have to check if they're pregnant, especially if we're using oral anticoagulants, because they can across the placenta. Now, heparin can't, but oral anticoagulants can. When we move on to the monitoring side of the house, we need to let the patients know that there is going to be a requirement for monitoring. Okay, so when you're planning on giving them medication, you need to educate them on the requirements for monitoring and educate them on certain risk factors associated with encouraging that Valcal's triad that we spoke about. Okay, so it's more about prevention. Okay, when we finally move in to the implementation, then we have a lot of things that we have to check, both for patient care and then also for a legal standpoint. So whilst they are getting the medication, okay, especially if you're doing an acute setting and you're using heparin, you need to monitor their signs and symptoms for early onset of bleeding. So tachycardia, hypertension, paleness, loss of consciousness, tachypnic, anything like that needs to be noted early. Okay, early signs of bleeding needs to be taken into account. So obviously the big hemorrhage you're going to see, okay, but look around the gums, okay, look around, look for evidence of stools, okay, darkening stools, things like that. Shaving cuts that won't stop, injection sites that won't stop bleeding, that sort of thing. You will need to have regular blood tests, so if you require bedside, make sure you have a machine on the bedside that you can actually monitor. When you're handling the patient, be careful. Okay, obviously be careful with them. Giving warfarin for the first time in high doses or heparin, you need to have the antidote ready. Okay, if you're using a heparin infusion and you're not familiar with the infusion pump, get someone to help you. Double check your mass, definitely, high risk drug. 2 independent checks must be done. Okay, when you move on to educating the patient, there is a ethical requirement and also a legal requirement that certain things must be done. You need to instruct the patient on what early signs of bleeding problems are. Gums, nosebleeds, darkened stools, unexpected bruising, things like that. If they're on warfarin, you need to educate them on foods that are high in vitamin K. Green leafy vegetables are a big one because they will absolutely reduce the effect of your warfarin. Tell them to avoid alcohol. 2 reasons. A lot of the clotting factors that are in the body are produced by the liver, pretty much except factor 4, which is ionized calcium, is produced by the liver, all the other factors. And alcohol increases the risk of injury and also causes vasodilation, so it's harder to stop the bleeding if it actually happens. In regards to our legal requirement, is once the education is done, it has to actually be written and noted in the documentation. So there's a special part on the actual medication chart that looks like the red box beside, and you need to say that warfarin education has been given before the person is gone. Now, because new drugs, oral drugs, are available before they leave the actual hospital, it needs to be noted that the oral anticoagulant instructions has been given, and they've also been given the warfarin book. Okay, but in this case, cross it out and say the dabigatran book has been given, along with the full education required. This also gets written into the actual patient notes with your time, date, all the rest of the usual stuff. Okay, so we're looking at name, signature, and date all over it. Now this is it's a legal standard that all nurses must do before discharging a patient on oral anticoagulants. Okay, so because you don't work in nursing a lot, it's a big thing for you to be aware of. Also, make sure you educate them on general over-the-counter medications that will definitely interact with the anticoagulant, especially the oral anticoagulant that they're on. Okay, that finishes pharmacology, anticoagulant agents. Hopefully you got something out of it. Okay, they are a high-risk medication, so please take it seriously and be humble enough to admit, especially if you are doing a heparin infusion, that you are not used to infusions or the particular syringe drivers or whatever the case may be, because a mistake in the measurement or a mistake in the rate can definitely mean adverse side effects associated with the patient. But until next time, take care.